special thank you to Dr. Rajshekhar for inviting. So I'll be sharing our experience with basically the latest large bore aspiration catheters which came to our country, I would say 1.5 to 2 years ago, and it has completely changed the treatment protocol, I would say, for intermediate high risk and high risk PE. So let's begin with this slide. We know that VT has a serious impact short term as well as long term. Whenever a patient with DVT comes, all he or she knows is there is a swelling in the leg, and most of the patients don't even reach at a proper place where they can be treated, and anticoagulation is the mainstay of treatment. Similarly, with pulmonary embolism, we know that a lot of patients of PE are diagnosed late, and we lose a lot of them. Especially even in 2025, there will be incidents that we may lose one patient every 6 months, even in the ICU, because of the delayed diagnosis. So coming to the DVT, I would say 50% of the expected patients who are treated with just anticoagulation develops PTS, which is post-thrombotic syndrome, especially when there is an involvement of the ILX and IVC. Out of this PTS, 90% are unable to work after 10 years. Mostly the young chaps, they'll come to OPD with non-healing ulcers, swelling, not able to walk, and then the entire circle starts and lands up in depression. So coming to P on the right-hand side, it's the third leading cause of cardiovascular death. And the most important thing is it's a leading cause of preventable death in hospital. And 30-day all-cause mortality is 15%. And when we treat it with anticoagulation or maybe lytics, 50% of them have residual vascular obstruction, which can lead to CTEPH. So these are important factors when we consider modern treatment, which is basically a Lytic-Free lab we are heading towards. And if you look at this slide, from 1999 to 2020, after the, I would say, the initiation of PERT program at Boston, we have still not decreased the mortality to a very high, I would say, figure, although there is a 50% reduction, but still it's still 25% mortality in high risk PE or a massive PE, what we call, and the risk of bleeding is still 5% with lytics. This is another important slide from MGH PERT data, where they say, like, if you discharge a patient with intermediate low risk, where there are no parameters to suggest that patient is intermediate high risk, so you will see like in 30-day all-cause mortality occurred after the patient left the hospital. So this submassive PE can get converted into a massive or intermediate high risk. So this is another important slide which has to be taken in consideration when you are discharging your patient. So look at this slide. On the left-hand side, there is acute PE. The clots are almost like cheese. And on the right-hand side, we have chronic PE, or the chronic clots, I would say, whether it has been taken out of DVT or pulmonary embolism. So once we have started taking the clots out, even if the patient says there is a history of 3 days, 7 days, like I would say 20 to 30% of the chunk is on the chronic side. And this is the slide which I have told, like PE treated with conservative therapy, up to 50% leads to what we call residual pulmonary vascular obstruction, and this leads to future development of CTEPH.